During this chapter, you'll study the key developments and personalities involved in knee replacement, and the factors that resulted in the design changes leading to modern knee replacements. The knee prostheses used today have been developed from implants tried in the past. The many design changes have been brought about by initial failures and the desire to improve the patient's function to as near normal as possible. Learning about historical implants and the reasons for their obsolescence will help you to understand the design features of modern implants, the development of families of knee implants, and the use of fully constrained prostheses. Early attempts at treating the arthritic knee started in the 19th century, and by the early 20th century used a variety of interpositional materials such as fascia lata, pig's bladder, and gold or silver foil. Themistocles Gluck implanted a hinged ivory knee replacement in 1891. During the first half of the 20th century, a variety of moulds were used to cap the ends of the femur. In 1923, the American Marius Smith Peterson used moulded glass and later interpositional metal. Peter Ring, a post-war pioneer of implants, recalls the routine list of options offered to patients did not include replacement with a prosthesis.
After the war, the routine treatment of arthritic knees and indeed of arthritic hips was arthrodesis, to fix the joint securely and obliterate all movement. And more time was spent on perfecting the fixation of the joint than in devising any suitable alternative.
It was in 1950 that McKeever used an interpositional metal plate on the tibial plateau, principally for rheumatoid arthritis. This was more successful than Mackintosh's earlier acrylic version used for correcting varus or valgus malalignment.
These pioneers were driven by curiosity rather than ambition. The innovators had an idea, they sketched it out roughly on a piece of paper, they persuaded a manufacturer to produce an implant which might, they hoped, work and might be commercially viable. And the conditions under which they were made were often relatively primitive. The castings were made commercially. They were polished by men in sheds rather than in a laboratory or even in a proper workshop. But they were sterilized at the end, and they were implanted with care and precision at least as it obtained at that time.
The evolution of the current knee replacement is logically traced to the Waldius hinged implant.
It's the most radical way of trying to produce a mobile rather than a fixed joint, was brought to my attention in 1950 or so, when I was shown and introduced to the Waldius implant. It was made in Sweden, or devised in Sweden. The insertion was simple. You opened up the knee joint, you divided the femur at its lower end transversely, you took off the top of the tibia and all the ligaments, of course, associated with it. You could then insert this bit, the femoral bit, up the shaft of the femur and the tibial bit into the center of the tibia. You put the screw in and your joint was then mobile. And the results from this were acceptable in that people could walk with this joint, largely in an extended position. They could also sit with relative comfort. It didn't allow a movement of more than 90 degrees, but that appeared to be adequate for ordinary practical purposes.
The Waldius implants lasted well because the stems were not cemented. They were free to move within the shafts of the tibia and femur to accommodate rotation at the knee.
The concept of Scher's knee was to produce a cemented implant which it was felt would be more stable. The disadvantage is that the articular surface for the patella is flat and relatively small and does not produce any stability for that part of the joint. In addition, this joint, as with the wall disc, is a straight articulation. It has no valgus offset to permit the normal angle of the knee to be maintained. Having to be cemented into position, it carries with it a considerable risk that loosening is a progressive phenomenon, and whereas the wall disc prosthesis, if loosened, was often asymptomatic, loosening of the Scher's prosthesis led to destruction of bone within the femur and the tibia, and some of these patients whose joints failed came at that time to amputation. The Stanmore prosthesis is a further development of a hinged joint. But here you'll see it has the advantage that it has a valgus offset, and it also has a platform for the patella. In addition, looked at from the side, it has the natural curve of the lower femur. It has to be cemented into position, but it does permit a rather freer range of movement than the earlier joints. There is the potential for almost 150 degrees of angular movement to occur in the knee. It also has a polyethylene spacer, so that the articulation is not of metal on metal, but it's of metal on polythene.
From 1970, less constrained designs were produced. To overcome loosening due to torsion, a variety of sloppy hinges were developed. The Sheehan, for instance, followed this principle and allowed some rotation to occur. While excellent results were achieved, the importance of soft tissue balancing was not really appreciated. Too much stress was being borne by the prosthesis, and therefore premature wear occurred. Gunston extended Mackintosh's ideas by putting femoral metal runners bearing on tibial polythene troughs. Acrylic cement was necessary to fix the implants to bone. The disadvantage was that the tracking was constrained. This meant that no allowance was made for rotation, with the result that premature loosening or wear occurred. The problem of constraint was overcome by unicompartmental prostheses, such as the St. Georg sled, which had a flat tibial surface. It was introduced in the early 1970s and survives with only minor changes to the present day. The concept of resurfacing the two halves of the tibiofemoral joint separately remained for many years. However, it eventually became clear that it was difficult to achieve accurate alignment and balancing, so the concept was dropped. The two halves of the femoral component became linked. The duocondylar knee, designed by Ranawat in 1973, linked the two femoral metal runners. This was size limited and without instrumentation. Anterior knee pain was a problem, as there was no patellofemoral joint. Patelectomy was often performed to overcome the anterior knee pain. A patellar flange was added in 1975 and became the duopatella. Ranawat, however, joined with Walker, Insel and Burston to develop the total condylar replacement. In 1975, Freeman introduced the Freeman-Swanson knee, also called the ICLH, Imperial College and London Hospital, with a simple roller metal femoral component and small polyethylene trough to fit any tibia. The latter resulted in sinkage of the tibial component. This was overcome by enlarging the tibial component. A femoral groove was added to aid patellar tracking in the ICLH-2.
Early joints, when you look at them, permitted movement, but did little more to restore function in the knee. As time progressed, the ambition of the surgeon and indeed of the patient became very much greater. The object was to reproduce the movement of the knee as it occurred in normal use. A range of flexion and extension, the ability to walk with the joint flexed rather than fully extended, the opportunity of sitting easily, indeed of squatting if you needed to, became more and more important. And the rotatory movement in the knee, which was one of the major causes of loosening of the early implants, was permitted in these designs, and the implant was therefore much less stressed than in the early ones.
The total condylar replacement was designed to replace both cruciate ligaments. It was the first to replace all three compartments, including the patella. The tibia was initially all polyethylene. The tibial geometry was dished in both the AP and ML planes, giving it a semi-constrained action which relied on correct tension in the collateral ligaments. This followed the principles established by Freeman and Swanson. Their early work on resurfacing prostheses was the first to explore the principle of soft tissue balancing, as well as surface fixation without stems. This was to reduce possible spread of infection along the intramedullary stems. As the name implies, the total condylar prosthesis resurfaced all of the articular surfaces. In addition, it relied on soft tissue balancing to provide alignment and stability. All these features predicated the development of dedicated instruments for insertion, an innovation that was soon to become commonplace.
Jigging systems for early knees simply consisted of a rod which you passed into the medulla, up and down the femur, and then you cut off the appropriate piece of bone at right angles to the rod. If you were lucky, you were provided with a flat plate to line up with. The success of this certainly depended on the skill of the particular surgeon. But as the knees became more and more complex, it was clear that in order to get the benefits of a modern type of knee replacement, you had to plan the operation, and the instrumentation had to become much more complicated than the early ones.
The 5 basic femoral cuts were first described by Hungerford in 1981 in the porous-coated anatomic, the PCA knee. In the last 20 years, modularity and revision systems have been introduced, but the basic design for primary TKR has changed less radically than during the previous decade. Several important areas remain under debate. These include the role of the posterior cruciate, patella resurfacing and mobile bearings, as well as fixation methods. Interestingly, the complex problems now faced in some revisions has led to a return of sloppy hinge prostheses, such as rotating platforms and super-stabilized components. These are needed to provide sufficient stability. However, such prostheses are rarely needed in a primary case where resurfacing, allied to accurate soft tissue balancing, should be the aim. The implant companies have created families of implants from unicompartmental through cruciate sparing, posterior stabilized, super-stabilized, to fully constrained prostheses. Often using the same instrumentation, this allows flexibility if there are intraoperative complications and reduces the amount of storage space. Instrumentation, size ranges, materials, quality control, distribution, education and research have all expanded to create the choice available today.
Once the manufacturers got into this, they brought an awful lot of resources to bear, didn't they? the range of implants. You see, you get one of these, a wall disc, nothing else, you can have that one, or you can go without. The range of implants here is almost endless. The sizes, the handing of the thing, the fact that your instrumentation permits an accurate positioning of this implant. None of that was available in the early ones. None of it was necessary in the early ones. If you had a good eye, you could cut the bone at right angles and you could put those things in.
The knee prosthesis family, from least to most constrained, is unicompartmental, posterior cruciate retaining, posterior stabilized, superstabilized, and rotating hinge. The selection of the type of implant depends on the integrity of the ligaments, the number of knee compartments affected, and the presence or absence of bone loss. So, to recapitulate, you should now know the key developments and personalities involved in the history of knee replacement, and understand the factors that resulted in the design changes leading to modern knee replacement.